Past history. Patient is known case of diabetes and hypertension in 5 years, not on regular medication for diabetes, not regular medication for hypertension, not on any goitrogenic drugs. No history of similar symptom in the past, no history of radiation exposure in the past. Surgical history. She has a history of cesarean section under spinal anesthesia without any intra and post-op complication reported. Menstrual history, attained menopause 4 years back. Family history. Having 2 children in healthy condition, no history of any thyroid disease in the family, no history of cancer in the family. Personal history. She is vegetarian, non-addictive, bowel and bladder habit normal, and sleep is normal. Socioeconomic history. She live along her husband and 2 children. Nuclear family. Husband is sole earning member. Lower middle class family according to the modified Kuppaswamy scale. Drug and allergic history. No any history of any medication for similar complaint or any non-allergic. Summary. This is the case of a 54-year-old female presenting swelling in the front of lower part of the neck that has been present for the past 4 years, gradually increasing in size, with no feature of hypothyroidism, with mild difficulty in breathing on lying down since 6 months. Should I proceed? Should I move? Yes. Examination.
As you should have asked in history.
Yes, sir.
What else you should have asked in history?
Any change in voice, sir?
Yes, that you mentioned. What about the preference to hot and cold? Is it mentioned in the history?
Sir, I have mentioned intolerance to cold.
Or cold.
Yes, sir. Intolerance to cold and intolerance to heat intolerance. Yes.
Okay, it's there.
Yes.
Go ahead.
Now examination, sir. Patient consent was taken. Patient examined in adequate light and in sitting position in presence of attendants. Physical examination. Patient fully conscious oriented to time, place, and person. Cooperative, moderately built, well nourished, no pallor icterus, lymphadenopathy, and clubbing. Temperature 98.6 degree Fahrenheit. Pulse is right radial 78 beat per minute. Regular rhythm, normal in volume and character. Blood pressure is 142/96. Right arm supine position. Respiratory rate is 18 breaths per minute. Regular rhythm, bilateral symmetrical. There is no any fine tremor, no peritibial myxedema, no acropathy. Palm are not moist. Eye signs are no any eye sign for thyroid toxicity present. Inspections. A swelling of size approximate 10/5 centimeters.
Hello.
Yes.
How did you see the tremor, and where else can you see the tremor?
Sir, we see the tremor in the hands, bilateral hands, by asking the patient to asking the patient to
show the fingers and stretch the hand, and you look for any tremor. Where else can you see tremor?
In uvula, sir, and in tongue, sir.
Tongue and uvula.
Yes, sir.
And which sign, eye sign are you talking about?
Sir, there is there any? I'm talking about the thyrotoxicosis sign, sir. In Darlap sign, sir, Neff-Zenger sign, Stalweg sign. These are the various signs which can we can check the is there any thyrotoxicosis or not, sir. Should I move, sir?
Proceed.
On inspection, sir, a swelling of size approximately 10 by 5 centimeter in front and lower part of the neck, extending from the thyroid cartilage to suprasternal notch, which was obliterated by swelling and laterally up to medial border of the sternocleidomastoid muscle bilateral. Skin over the swelling normal, surface smooth, no scar sinus or any dilated vein, no pulsation over the swelling visible, swelling move with deglutition, no any facial congestion on raising bilateral upper limb. Palpation. Inspector finding and confirm no local rise in temperature, non-tender.
Hello, in inspection,
Yeah.
can you make it more means apparent? What should be done to see the swelling? If there is a small swelling or since in this case it's quite big one, so there is no need to do that method. You know any method to improve the visualization of thyroid? Did you get my question?
No, sir.
To make it more prominent, what could have been done?
Sir, to make it more prominent, sir, Pemberton sign we can, by Pemberton method, we can check by asking the patient to fold his hand, keep his hand over
the retrosternal. That is for retrosternal. To make a small swelling more prominent, what can you do? Pemberton sign is for the retrosternal goiter.
So,
yeah, somebody has answered from Mewat. Somebody answered from Mewat.
yes.
It is Pizzolo method. What is that?
Yes, sir. Pigello method, yes, sir. In Pigello method, sir, we flex the neck and raise the thyroid, shift the thyroid lobe by the right hand if we want to check the left side of the thyroid lobe.
This is Lay's method, not Pizzolo method. That is Lay's method. Lehi.
Sorry, sir. Yeah. Pigello method.
Extend the neck and keep fingers flexed behind the nape of the neck and make it more prominent. Just extend the neck and apply pressure from back by hands, so neck will be more prominent. That is this method is applied for if there is a small swelling, so it can become more prominent. Okay, go ahead.
Thank you. On palpation, sir, inspector finding and confirm no local rise in temperature, non-tender, size 10 by 5 centimeter, extending from mid of the thyroid cartilage superiorly and inferiorly border not palpable, as swelling extend under suprasternal notch, obliterating it, and lateral extend up to mid of the bilateral sternocleidomastoid muscle. Skin over the swelling can be pinched, surface is nodular and firm in consistency. All margin palpable and well demarcated except inferiorly. Carotid pulse palpable on both the side and not displaced. Trachea not palpable. No other swelling palpable in the neck. Lateral border palpable and rounded. No stridor heard. Percussion over the manubrium, dull note. Auscultation, no brew heard. Systemic examination. Respiratory system normal, vesicular breath sound. Cardiovascular system S1 and S2 normal, no murmur. Per abdomen soft and non-tender, no hepatomegaly, splenomegaly, bowel sound heard. Central nervous system, no neurological deficit. 90-degree Hopkins endoscopy was done, which show bilateral vocal cord equally mobile and intact. Summary. A 54-year-old lady with complaint of swelling in front and lower half of the neck, which is gradually progressive in size and mild difficulty in breathing on lying down without any feature of hypo and hyperthyroidism. On examination, there is a 10 multiplied by 5 centimeter size swelling in thyroid region with smooth surface with well-defined margin except inferiorly extending retrosternal and moving with deglutition. My provisional diagnosis is a 54-year female suffering from non-toxic multinodular goiter with retrosternal extension with mild compressive symptom on lying down.
4-year female is not a diagnosis. Have you heard?
Yes, sir.
This is not the diagnosis. You are saying 54-year female is a part of diagnosis.
Yes.
Say multinodular goiter and extension wherever you want to say.
Okay.
Any investigations were done?
Yes, sir. After routine investigation, sir, we done thyroid function test, USG neck, FNAC, CT scan and MRI. And sir, for fitness of the surgery, X-ray neck, epilateral, and X-ray chest PA view.
What are various findings?
Findings, this is the ultrasound neck, which show multinodular goiter I described above. Should I move, sir? This is the CCT neck, sir.
The nodules are hemorrhagic or non-hemorrhagic?
Non-hemorrhagic. This is the CCT neck, sir.
Yes. What are the findings in CECT?
We find sir the heterogeneous enhancing well-defined oval lesion measuring 5 by 4 by 5.5, 6.5 centimeter. The lesion is seen indenting the trachea esophagus posteriorly and displacing them to the contralateral side, reaching up to prevertebral space. This lesion is also seen above left sternocleidomastoid muscle, left sternohyoid and carotid vessel laterally, above anterior jugular vein with focal contour bulge. Posterior inferiorly, the lesion is seen above the lateral subclavian artery. No obvious infiltration into the surrounding structure seen.
CT scan photographs.
And conclusion is, sir, bulky bilateral lobe of thyroid with isthmus with heterogeneous enhancing lesion as described, suggestive of multinodular goiter. This is the FNAC report, USG guided FNAC, which show the category 2 benign follicular nodule. Bethesda scoring grade 2, sir. This is the picture, photo of the patient.
Why ultrasound guided?
Yes, sir.
Why ultrasound guided FNAC?
For the more accuracy, and sir, for more accuracy of the report, sir.
Can you explain more? What do you mean by more accuracy? You have large nodule, palpable. A small lesion, then you might have to. But here, why you want to go for? What do you mean by more accuracy?
Sir, with the ultrasound guide, we can
Don't persist with the ultrasound. What is being said is that there was no need of ultrasound guided because it's a big nodule. You can go anywhere. If it was very small where you cannot reach, in that case, ultrasound guided should have been better.
Yes.
Okay. Good. Dr. Gupta. Dr. Gupta, you want to say something else?
No, that is okay, sir. Thank you.
When the ultrasound to escape from the core of the nodule or from the swelling, that way it could have been this thing, but the explanation is that to improve the yield or to fit into the core, which is the site from where the aspiration should be done.
Sir, sound is not clear, sir.
Whose? Mine.
Sir, sorry, sir, not getting.
Am I audible?
Yes, sir. Yes, sir.
To improve the yield, the people use an ultrasound so that the cystic swelling which is there, so the core of the swelling can be approached by the use of ultrasound. You can say if you have used the ultrasound, because as sir said earlier, the smaller nodules can be aspirated with the help of ultrasound. But in your case, it was a big swelling. So to hit the core of the swelling or the core of the cyst, so that to have the better yield, you have used as ultrasound.
Okay.
You have not told about the ultrasound. What was the finding? Is it a solid swelling or a cystic swelling? And what is the triads?
And yes, what was the grading on the ultrasound?
Yeah. Have you told? I don't think
No,
so.
sir.
So, I mean, ultrasound makes more sense in thyroid rather than straight away going for CT scan. Isn't it? You have not done ultrasound?
Good evening, sir. I am Dr. Avneet, AP from Adesh Medical College.
Ji, ma'am.
Sir, we had gone for ultrasound
We have gone for
first.
ultrasound, sir.
And so we had spoken to the radiologist. They told us verbally only that it is thyroid 1. I had asked them to mention it. So they said we have written that it is multicystic. So that itself, had it been other thyroid, we would have mentioned, but they told verbally that it is thyroid 1.
Okay, thyroid 1 and multicystic. Then it makes more sense that you have gone for ultrasound guided FNAC.
Yes, that because pathologist also didn't want to hit any other area or didn't want to yield just hemorrhagic or blood. So because of that, and also if there was any suspicious lesion or area, if there was visible, so we thought that we'll go for ultrasound guided FNA.
Yeah, they say always.
Ultrasonography should have been told first, and then.
Sir, he told ultrasound first only, and then we went for CT to see compression and then the retrosternal extension.
Multicystic is there, so to have a better yield, you will go for USG guided FNC. So that is correct. Dr. Sachin, so you have to answer like that only.
Struggle with Pemberton sign is more.
FNAC is quite difficult, especially reporting FNAC in thyroid. One pathologist has to be very expert. In this case, it was simple goiter, so it was not a difficult. Suppose it is malignancy. How can you improve the result of FNAC reporting?
Very difficult to differentiate if is that lesion is invading the capsule of the thyroid.
Then we have to go for true cut biopsy.
The earlier question was, there are very small cells, few cells, and sometimes they report it cannot be reported or it may be just. How can you improve the results, especially in cases where you suspect carcinoma? This is not a question for ENT person, but theoretically, this is for pathologist. But you must have read since you are presenting. The question is clear or not?
Yeah, my question is clear, sir. Yes. We have to go for CT scan, sir, if there is any.
We are asking for FNAC slide.
Sachin, the question is of FNAC. So where exactly your aspiration should have taken place, so that you could have diagnosed whether it is anaplastic carcinoma or not.
No, don't.
If possible, you can do immunohistochemistry. Okay. That way you can give 100% result are not given by any person, maybe any pathologist, but you can improve the results, especially to rule out CA of different type or rare type. Is it clear?
Yes.
Proceed.
Finally, sir, treatment is a total thyroidectomy. And this is the specimen, sir, we have removed.
Why total?
Yes, sir. Because it's a multinodular goiter. It's a very large involving both the
Multinodular of the right side, I think so.
No, sir, it's involved both the lobes, sir, and isthmus.
Okay. Isthmus also involved.
The CT scan picture in this your presentation.
Only reports I have put here, sir. No.
No,
You,
no reports.
Dr. Sachin, you must be having it. You were having it. देखो एक बार.
Sachin, just repeat your CT findings.
CT finding, yes, sir. Right and left lobe of the thyroid appear bulky, measuring 2.2 multiplied by 2.4 multiplied by 4.5 centimeter and 2.7 multiplied by 2.6 multiplied by 3.8 centimeter respectively. Isthmus also appear bulky and show a heterogeneous enhancing well-defined oval lesion measuring 5.4 multiplied by 5.5 multiplied by 6.5 centimeter. The lesion is seen indenting the trachea and esophagus posteriorly and displace them to contralateral side, reaching up to prevertebral space. This lesion is also seen abut left sternocleidomastoid muscle, left sternohyoid and carotid vessel laterally, abut anterior jugular vein with focal contour bulge. Posterior inferiorly, the lesion is seen abut the left subclavian artery. No obvious infiltration into the surrounding structure seen. Yes.
What is covered trachea? It should have been there in this case.
सर आपकी आवाज क्लियर नहीं है सर बिल्कुल भी.
Covered trachea.
Scabbard trachea is sir the posterior atrophy of the posterior wall of the trachea. This is known as the scaphoid trachea.
Posterior wall.
Yes, sir.
Posterior wall. The lobes are pressing from the side, so how can the posterior wall be atrophied? What is covered?
So, Sachin, the tracheal rings are C-shaped. Posteriorly, there is the deficiency of the ring.
जी.
You have got such a big lobes which are pressing on the trachea. How can it be posteriorly? The lobes have to press from the sides.
Dr. Ishwar, good evening. Your voice is breaking in between. It's not clear. Dr. Ishwar, good evening.
Good evening, Dr. Singhal. I'm asking what is
आपकी आवाज बीच में ब्रेक हो जाती है, सुनती नहीं.
अच्छा, ये अब आ रही है?
हाँ, अब ठीक है.
मैं यही पूछ रहा हूँ what is scabbard trachea and what do you mean by scabbard?
I could listen it, but Sachin was not able to.
Yes, scabbard trachea, sir. The wall compression of the wall of the trachea from lateral side.
So earlier you are saying from the posterior?
No, sir.
No, sir.
No, you had said. So, okay, so the continuous pressure on the wall of the trachea literally leads to what?
What was the intraoperative status of trachea in this case? Since the patient had a stridor or lying down.
No, sir. Patient has no any stridor, but there is a breathing difficulty on lying down of position, sir. And
she had a respiratory distress on lying down, na?
your voice is breaking, sir.
She had a respiratory distress on lying down. She couldn't lie down on the supine position. You mentioned as one of the complaints.
Yes, yes, sir. And in this, on intraoperative findings, the trachea is shifted for the left side, sir, and compressed.
I think the CT scan findings are suggesting that the trachea is being compressed by the lesion in the isthmus, which is 5.4 into 5.5 into 6.5 centimeter.
Yes, sir.
So it's compressed from the anterior side. The patient must be on stridor. And it,
Sir, yes,
No, sir, no. The patient was
intermittent.
having a little bit of distress on lying down, but there was no stridor at
No,
any
sir.
point of time.
And so we had done FOL also beforehand, flexible laryngoscopy, and there was no compression as such seen of the lumen also.
Your
So
CT scan finding are suggestive of the intention.
yes, sir, it was. Yes, sir, but when we were also suspecting that there might be trachomalacia, she was of course having pressure symptoms while lying down.
So,
So intraoperatively, there was no tracheomalacia at all. And there was
what
no
intraoperative step you could have taken to prevent this tracheomalacia or compression sufficiently?
So just to be on the safer side, we have kept the endotracheal tube for more than 24 hours post-operatively. And then we had removed, and everything was, the post-operative period was uneventful.
Do you think by 24 hours the cartilage will regain their strength?
Sir, that's true, it won't be. But then there was no strider.
What is the maneuver which is done to prevent this collapse of the trachea? That's what I'm asking you.
Not in this case, in any other case.
In any other case, if there is a frank tracheomalacia,
How it is managed?
Hello. Good evening, Dr. Yadav.
Oh,
Sir, I'm interrupting only to tell you that this case presentation is by Sachin Garg, and he is not being given a chance to speak at all. I want questions to be directed at him. If he is not answering, then only his teachers can take over.
he's lucky.
I find this discussion is going on between the teachers only.
In this case, I would say
Student is being ignored.
Good evening, Dr.
Kindly
Pasi.
focus on the student.
Good evening, Dr. Pasi. So we will allow
Yes,
allow
yes.
Dr. Sachin to speak up. Yeah, Sachin, please go ahead.
Yes, sir.
Yes. Yeah, please.
Dr. Sachin,
Yes, sir.
your presentation was very good. I would say to the extent of excellent, and I must compliment your teachers also who helped you to prepare this. It was really good. Unexpectedly, it was very good.
Thank you.
So I must compliment you as well as your teachers.
Thank you.
Sir, your words are so encouraging. And Sachin somehow is a good student, but today, Sachin, please go ahead. You're doing very well, huh?
So
Thank
that's what I said, excellent. Check out. In your case,
Yes.
there is no question of recurrence according to the surgery. So yes.
Yes, sir.
But suppose there is a malignancy. So what is the rate of recurrence?
10% cases, sir.
And it depends on the surgeon and the disease. So what are the signs which tell you that there can be a chance of recurrence so that you become cautious and do better dissection? So what are various parameters or signs or whatever you want to say which indicate that there is a chance of recurrence?
Sir, if there is any infiltration in the adjacent structure, sir.
वो तो भैया बहुत बात की बात है. Before surgery, simpler one, and then go to the difficult one.
If it is hard, sir, if it is hard,
I will start. It is more common in males. One, if the size is more than 3 centimeters, the chances of recurrence is more. So
more
start
in young age, sir.
and you are going to the last stage.
And if it more in in the earlier age of the life, extreme of the life, sir, it less than 24 years.
No, you are wrong. The younger the patient, chances of recurrence is more. Extreme age pe to patient may die before recurrence. If suppose you are doing an 80-year patient and the chances of recurrence is very less. I have told 3 points. Now you add 1, 2, 3 more. It is expected out of you. Since you have presented so well, I expect that you will be able to answer.
If there is an hoarseness of voice, sir.
Okay.
There is any compressive symptoms.
Okay. ये नहीं है वैसे. You want to say, I may say yes, but these are not. And if you don't know, कोई बुरी बात नहीं है. मेरे को भी शायद पूरा नहीं पता, तुम्हारे को छोड़ो ही. मेरे को 40 साल हो गए इस सब्जेक्ट में, more than 40 years. If there are more lymph nodes, okay, and when you are doing surgery, if you have to go to more laterally to do surgery, that means chances of recurrence will be more. And then you can go to the, what you were saying, if there is infiltration or if it is anaplastic carcinoma or whatever. So these indicate, well, earlier one I told you, in those cases you have to be more cautious
Yes.
for this section. Is it clear to you now?
Yes, yes, sir.
Oh, very good. चलो proceed and अभी तो बहुत एक्सपर्ट लोग बैठे हुए हैं, डॉक्टर ईश्वर तो मास्टर है इस चीज में। और डॉक्टर पासी ने अभी ज्वाइन किया, उनसे तो बहुत कुछ सीख सकते हो। थायराइड तो बहुत दूर की बात है, और बहुत सी है। सबसे इंपॉर्टेंट चीज क्या सीख सकते हो उनसे? यू कैन आस्क हिम द एड्रेस ऑफ फाउंटेन ऑफ यूथ। Is it were you able to listen? Sachin?
Yes, yes, sir.
You can ask him address of Fountain of Youth from Dr. Pasi. After the discussion, you can let others ask.
No, sir, we have attending 3 to 4 conference and which under Pasi sir.
कभी फाउंटेन ऑफ यूथ का एड्रेस पूछा तुमने उनसे कि जवान कैसे रहते हैं? वो पूछना, वो काम आएगा। 20 साल और एक्स्ट्रा सर्जरी करोगे।
Proceed.
अब तो सवाल पूछने में क्या करें? If there is infiltration of trachea, what you do? What is expected to do?
Sir, if there is an infiltration of trachea, then
ideal situation, what should be done?
We should go for tracheostomy, sir.
ट्रेकियोस्टमी तो अब ऐसे ही चले जाते, इसमें थोड़ा सा और बड़ा होता तो भी ट्रेकियोस्टमी कर देते। ये आंसर तो तुमने ना बड़ा डिसअपॉइंटिंग दिया।
Sachin, intraoperatively, if the trachea is infiltrated, then what will you do? By the tumor, if the tumor is infiltrating trachea, then what will you do intraoperatively?
Awake intubation, we should do.
Some people do desiccation of part of this tumor wherever they feel. What is the ideal one? Resection and anastomosis. Okay, even if you don't know, you are still in training stage, so it doesn't matter. Okay, but resection and anastomosis is not that simple. It is much more difficult than thyroidectomy. Okay. Have you heard? No.
Yes, yes.
Sachin, if your presentation is over, you can stop sharing your screen so that we can have a discussion.
What was the histopathology? Hello?
Yeah.
Sachin, what was the histopathology final?
It's sir, benign goiter, sir. It's
Is that the final report?
yes, sir.
Okay.
I didn't put here, sir, but it's
Sometimes the FNAC is something else and the biopsy comes at something else. This is very common in thyroid.
Yes, it is very important.
And that is very important to follow.
Sachin?
Age, less equality, more than 6. Male gender.
Sachin?
Yes, sir.
Operatively, if you suspect that this is a malignancy,
Okay, sir.
what modification you will do? Or anything else you like to do to rule out malignancy? Suppose intraoperatively you think that this is a malignancy. This looks to be a malignant tumor. What do you do? Somebody answered from Mevat. Okay, what is the role of frozen section in thyroid?
Sir, in frozen section on the OT table, we can check whether it is a malignancy or benign, sir. On the OT table, we can.
Is it always? It's not always possible, na?
Yes, sir.
So when it is not possible to comment. Okay, I'll change the question. Yes. Very right, Dr. Akash. Yes, it's a follicular neoplasm. So how do you differentiate benign and malignant follicular disease? On what basis? It's a simple question. How? The question is how? Biopsy histopathology is okay. That is correct. Excisional biopsy, but then certain people are helping you out. Yes. Now it is correct. It's capsular invasion. Dr. Pooja, yes, right.
But sir, it's on FNSC, no, sir? Capsular invasion.
No. Capsular invasion you cannot see on FNAC, dear. On histopathology only you can see of the specimen. So that means during surgery, even if you are suspecting that this is a malignancy, the frozen section is not going to help you. Right? Only histopathological report regarding the extension of tumor. Right? If it is extending to the boundary, the outer limit, right, it will tell you. If you have enough cuff retained of the tissue that it is not extending outside the limits of thyroid, then you are safe. Okay, sir has also commented upon IHC. Have you read? Can you throw some light on IHC? I mean, which tumor marker is used for IHC in thyroid?
Calcitonin, sir. Serum calcitonin.
Any other? Yes, calcitonin can also be used. But any
And
other?
CEA, sir. Chronioamylonic antigen, sir. And
something which tell you that this tissue belongs to thyroid, very common.
TSHA. Cytokinin, sir.
That is for if you do a total thyroidectomy in papillary carcinoma, yeah. Now here we can. Hello sir, Dr. Ravi. कैसे हैं? सर ने आंसर दे दिया.
टीचर ही आंसर.
सर पर्ची डालना जरूरी होता है. Haemoglobin labeled markers. So they will differentiate, thyroid tissue from any other tissue. That is how you can differentiate secondaries also.
Dr. Sachin, can you tell us some post-operative management of this patient? You have done almost a total thyroidectomy, so you must have removed parathyroid also. So yes, this patient is going to develop hypocalcemia or catnip.
We have to regularly check, sir, calcium level of the patient, sir. And by giving the calcium regularly and thyroid stimulating hormone.
So bedside calcium, IV calcium should be lying there, and everybody should be instructed. In case of tetany, he or she has to be given calcium, and that too intravenously, slowly.
Slowly, yes, sir. Calcium gluconate, yes, sir. Yes.
Okay, so that is very important.
Yes.
And plus, suppose this patient develops respiratory distress in the post-operative period, what do you do? Do you put a drain in the neck or not?
Sir, if there is a respiratory distress, we have to check whether it is from any complication, any hematoma.
Okay. My question was, do you put a drain in the neck?
No, sir. We have to re-explore again, sir.
Are you putting drain regularly after thyroidectomy or not?
No, sir.
You are not putting. So then there are chances of hematoma which can lead to respiratory distress. So what will you do in that case?
We explore it.
Dr. Ishwar, your voice is not clear.
Quite close to the speaker. Am I audible or not?
Yes,
Very feeble sound.
Yes, okay.
Yes,
अंदर सुनाई दे रहा क्या नहीं दे रहा?
yes,
yes,
yes.
sir, there
अब
is.
सुना, अब सुना है.
टोटल थायरॉइडेक्टमी के बाद तो ड्रेन डालना ही डालना है, ड्रेन के बाद तो ड्रेन डालना ही डालना होता है.
That's what. Yeah, that's what. But they are not putting it.
नहीं सर, डाला था ट्रेन.
That's
I was waiting. He is
No,
telling.
no, sorry, sir. Yes, sir. Yes, sir. They have put it. Sorry, sir.
सर ड्रेन डाला था
Yes,
and
yes,
after 10 ml 2 दिन आया, उसके बाद ही
Yes,
निकाला
sir.
था.
Yes. After 10 ml, we have removed, sir. Yes.
उसके
Sorry,
बाद
sir.
निकाला.
Dr. Sachin, if you have put a drain, you have to regularly check it. Is it not fully deflated or so? And keep on checking it. Sometimes the drain is blocked with a clot.
Yes, sir. We are regularly charging the drain.
Then the
Is
patient can die. Okay, so these are the points which have to be kept in mind in the post-operative.
put the drain, yes, sir.
Okay.
Yes, sir. Just to add, sir, with all due respect, yes, sir. Parathyroids we had saved intraoperatively along with the fat surrounding it, or inferior thyroid,
Sorry.
parathyroids, and uske baad intraop after 48 hours we had gone for calcium, corrected calcium check kiya tha along with albumin. So patient वैसे we had already started calcium from the first day, but the patient's corrected calcium didn't go below 8.
Okay.
Dr. Sachin, how you identified the parathyroids? Ma'am has told that they have preserved it.
Yes, sir.
So how will you identify parathyroids?
Sir, parathyroid gland identified by its color and its location, sir. It's a caramel color and light yellowish and brownish color, sir.
Yes. You were talking about location also. Can you elaborate on that?
Yes, sir.
Can you be more elaborate? You said location also.
Location, yes, sir. We have identified for the superior parathyroid gland and the superior pole of the thyroid, sir, and inferior thyroid gland at the posterior side of the thyroid, sir.
Parathyroid are constant and which pair is unconstant. So they can be variable in feature. And how do you present?
सर आपकी वॉइस नहीं आ रही सर बिल्कुल भी.
ये तुम्हारा स्टैंडर्ड एक्सक्यूज हो गया यार, रुपेंद्र को सॉरी है.
नहीं डॉक्टर ईश्वर आती नहीं है, बीच में आवाज नहीं आती है.
मैं ये पूछ रहा हूँ कौन सी पैराथायराइड कांस्टेंट होती है, कौन सी वेरिएबल होती है, एंड हाउ मेनी पैराथायराइड आर देयर इन द बॉडी.
Sir, there are total 4 parathyroid glands, but it may be 20. But on normal person, there are total 4 parathyroid glands, and superior parathyroid gland is more constant in their location, and inferior parathyroid gland may be mediastinal, may be superior, inferior, and lateral.
And superior parathyroid are in which in relation to which vessel?
Sir, voice नहीं आ रही सर आपकी बिल्कुल भी voice नहीं आ रही.
Superior parathyroid are in relation to which vessel? Very close to the speaker now.
माइक लिखा हुआ सर.
मैं ये पूछ रहा हूँ कौन से वेसल के रिलेशन में होती है सुपीरियर पैराथायराइड.
Sir, superior parathyroid, sir, superior thyroid artery, sir.
No.
And how do you preserve their blood supply?
Sir, we preserve the blood supply by ligating the blood vessel as much as possible. This is written there, sir. Sir, we preserve the blood supply by ligating the vessel at distal end of the inferior thyroid artery, sir.
If by chance it has been taken off, it is off, then what do you do next? Where do we re-implant it?
Yes, it will be reimplanted in the sternocleidomastoid muscle, sir.
What about how to identify the recurrent laryngeal nerve? What are the various methods?
Sir, recurrent laryngeal nerve can be identified by the lateral approach. In this, we can derive triangle in which we can identify the recurrent laryngeal nerve, and in which there is a medial border is formed by the trachea and esophagus. Laterally is formed by the carotid artery. Spirally, it is by the inferior thyroid artery, sir. In this, this is the safest method to recognize the recurrent laryngeal nerve.
Retrograde method. Hello.
सर
Hello.
आवाज नहीं आ रही सर बिल्कुल भी.
Retrograde method. Retrograde method.
Sachin sir is asking if there is any retrograde method also to identify recurrent laryngeal nerve.
Yes, sir. By identifying the barrel ligaments, sir.
Tracing the nerve from the point of entry in the larynx. Because that point of entry is fixed, it is anterior to the thyroid cartilage, the thyroid joint.
Sir is telling that there is a point of entry into the larynx. Recurrent laryngeal nerve, where it is entering, from there we can trace the nerve. So that is a retrograde method of identification of recurrent laryngeal nerve. So, okay, Sachin, what is Sarnia's classification?
So Sarnia's classification is to identify the external branch of superior laryngeal nerve. This is categorized by category Sarnia's 1, Sarnia's 2. In Sarnia's 1, if there is a recurrent laryngeal nerve 1 centimeter distal cranially to the upper pole of the thyroid, this is category 1. In category 2, sir, it is within 1 centimeter of the upper pole of the thyroid. It is category 2. Further, it is divided in category 2A, category 2B. And category 2B is the caudal presence of the external branch of recurrent laryngeal nerve, which is the most common injury point of the external branch of superior laryngeal nerve.
No, it is related to some centimeters.
Yes, sir, 1 centimeter, sir. Category 1 is within 1 centimeter. And category 1 is, sir, more than 1 centimeter. And category 2 is within 1 centimeter.
Okay. Yes. Questions from the experts.
What is thyroid edema? What is thyroid edema?
Thyroid edema is thyroid vein, sir. It's a fourth thyroid vein, sir.
Is it vein? Is it vein? Hello?
Thyroid edema artery, sir.
So, can probably thyroid artery or vein. Is it from where?
What is it? From where this branch is coming?
Supply.
Teaching है इसका इनाम
Arise from the arch of aorta or from the brachiocephalic trunk.
Brachiocephalic trunk.
It can arise from the arch of aorta or innominate or brachiocephalic trunk also. So this is a anomalous artery.
If there is a bleeding, postoperatively in the thyroid vein or vein is filling up, what is the most likely site of bleed? What is the most likely site of bleed?
Most side bleed cell.
Ishwar sir, can you repeat the scenario you are giving?
If the vein is filling up rapidly and you feel there is a bleeding in the thyroid postoperatively, what is the site of bleeding?
Postoperative side of bleeding, sir.
Surgeon, if there is a rapid filling of the drain in the post-operative period, so sir is asking what is the most common site of bleeding or what is the most, what can be the most common cause?
The spirithyroid artery, sir.
Very good. That is the commonest site of bleed. So you should take some time to ligate the superior thyroid vessel. That is the site where the ligature slips.
Any other questions?
Can I ask one question, Dr. Nitin from GMCH?
Yes, Nitin.
Which side nerve is more likely to get injured during surgery? Recurrent nerve.
Sir, right side is right recurrent laryngeal nerve is more common to injury, sir.
Reason?
It's a more recurrent course, sir, and it's more superficial and lateral side, sir.
Okay, and another reason can be sometimes it can also be non-recurrent on
Yes,
the right side.
Yes, sir, maybe non-recurrent.
Yeah. Otherwise, left is more prone to palsy because of its
Yes,
longer
sir.
course.
Because longer course, yes, sir.
Incidence of non-recurrent laryngeal nerve, right side. Hello, Dr. Sachin.
Yes, sir.
What is the incidence of non-recurrent laryngeal nerve on the right side?
Non-recurrent laryngeal nerve incidence is, sir, 5 to 15%, sir.
Oh, it is not that high. It is even less than 1%. Till now, in 30 years, I have seen only one non-recurrent laryngeal nerve. And incidentally, I also injured that.
So truthful.
Hmm?
You are so truthful. I think we should complete this discussion now. Raman?
Yes, sir.
And you hear the
So, Vipin sir, you have any questions to ask?
I think we have covered more or less everything.
Okay.
If you want, because this is a benign case, we can switch discussion to malignancy. Furthermore, I mean, we can discuss.
Yes, sir. Yes, sir. You can give the case scenarios and you can ask the question, because it is not necessary they are going to get a benign case only in exam. So you can give the case scenario for residents' interest.
If you think that the histopathological report comes out to be medullary carcinoma, anything else you want to rule out? If you have a medullary carcinoma, thyroid along with the
Yes, sir. If there is medullary carcinoma, then we have to amend to, it's connected with the other tumor also. Then we have to go for MEN 2A, MEN 2B, and a pheocytochroma.
So what is the presentation of pheochromocytoma?
There will be some hypertension, and there is a
yes. Basically, what is happening? What is in the system? Catecholamines.
We have to check for 24-hour urine catecholamines, sir.
So how you cannot measure catecholamines like that. You have a byproduct for that. What is that? People are helping you. You can just you have to complete the full form. It's VMA. VMA is
नहीं कहाँ से
with lactic acid, sir.
Now answer.
Sachin, what does VMA stands for?
He has already answered it.
It's vinyl mandelic acid, right? Okay. One you have covered. So that is pheochromocytoma part has covered. What else is there in MEN?
Sachin, do you know MEN 1, MEN 2A, MEN 2B? Can you enumerate?
Sir, MEN in which sense pheocytochroma, thyroid.
So which one you're telling? MEN 1 or MEN 2?
MEN 1, sir.
Okay. So if you don't know, it's okay. You can go and read.
No, sir. Actually,
no issue.
Sachin, what is MEN 1 and MEN 2? Okay, what is full form of MEN?
Sir, multiple endocrine neoplasia, sir.
Okay, go ahead then. What is MEN 1, MEN 2? Which one is more sinister? Either 1 or 2?
MEN 2 is more dangerous, sir. And it's a pituitary adenoma, pheocytochroma. And hematoma, and pituitary 2, sir, there is hematoma, a ganglionosis.
Pituitary, pheo, and medullary carcinoma. Okay. And another is when you have an involvement of parathyroids. Right? Okay. And then in certain cases you will have this fibromas also, in addition, tongue fibromas. That is 2B.
In 2B, you have marfanoid features and multiple neurofibromas.
Yes, sir.
Along with medullary C and pheochromo. Okay. Right. So, Vipin sir, any advice, any piece of advice for the residents? What all topics they need to be read for their exam point of view in thyroid?
My advice sir, will be only that they need to be very thorough, and simple things should not be missed. Starting from anatomy of thyroid, then presentation, and then you can go for surgery. So it is always a stepwise approach will be better. That so for any surgery you need to know indications, contraindications, procedure, complications. So if you are thorough with that, you will succeed.
Great, sir. Ishwar sir, any final advice for the residents?
Residents should discuss among themselves, and they should discuss the findings with the consultants. The more they discuss, better they will be in presentation, and they will retain more. So they should try to teach the juniors first year or second year, since they are the exam going. So more you discuss, and that will help in reading and retaining, and that is what is done in your case presentation. So I wish all the residents good luck, and they come out with a flying color.
Thank you, sir. Thank you. Also, Ravi sir also advised all the residents to please go through the latest ATA guidelines also in a case of for a thyroid management. So you may get a question on management of a thyroid nodule. So how to proceed with that? So you should know. So SPS Yadav sir.
A general advice is case discussion is very good, but residents, if they get a case which they don't know, they should approach a consultant who is sitting there. Even if he scolds you, go to him or her. So that teaching is much better than discussing a case in a month. Daily OPD, some case, not of thyroid, of any case, which they are not able to understand, they should go to the consultant and discuss. This is my simple advice.
Right, sir. So, Gil sir.
I would like to first thank you, in fact, for taking such a good initiative. And I'm really grateful to Dr. Yadav, Dr. Ishwar Singh, Vipin, Dr. Surinder, and Dr. J.C. Pasi sir, for all your kind words and all your words of wisdom. In future, I'll see to it that my resident is even more prepared, and he would deliver a better talk in future. So thank you, sir. Thank you once again to all of you.
Thank you, sir. So, Rupinder sir and Surinder sir, please you can conclude the session, sir. Last final words. Rupinder sir, Surinder Singhal sir.
Dr. Surinder.
Yeah, Dr. Ranga. Good evening, sir. Good evening, Dr. Yadav.
Good evening.
I think Dr. Ishwar and Dr. Yadav has already pointed out that the residents should not hesitate in discussing the cases with the consultants. I think daily in OPD, 1 or 2 cases they must discuss. That will improve their confidence when they appear in the exam. And I think it was a good presentation from Adesh Medical College. And I thank Dr. Gill and his other faculty members. And I congratulate the boy who presented, Sachin, also, and wish him all the best for his exam. And I must thank the moderators. As usual, Dr. Ishwar was good, but his voice was breaking in between. I had to point it out. And Dr. Vipin Gupta from Solan, and my teachers, Dr. Yadav and Dr. J.C. Pasi. Thank you, sir. Thank you.
Yes, Rupinder sir. So,
good evening to all. I think it was well interactive Zoom meeting, and thank you, Dr. Sachin Garg, for presenting this thyroid case. It was good case to discussion, and thanks to experts, Dr. SPS Yadav, ex-HOD from PGI Rohtak, Dr. Ishwar Singh, Director, Indira Gandhi Hospital and Ambedkar Medical College, New Delhi, Dr. Gur Paramjit Singh Gill from Adesh Medical College, Dr. Vipin Gupta from Solan. And I am thankful to all to participate in this Zoom meeting. I think Dr. Raman, today attendance is good.
Yes, sir. We had maximum 55 attendance. 55 participants were there.
This is respectable.
Yes, sir. Yes, sir.
And in future we will also increase the participation of this Zoom meeting. And thank you, Dr. Raman. This is the brain behind this show, Dr. Raman and Dr. JC Pasi. And we will discuss this audiology part
On 17th, sir. 17th.
on 17th, the remaining part of that audiology will be on the 17th.
Yes, sir.
Thank you, everyone. Thank you all.
Thank you, sir. Good evening, sir. Good evening. Good night.
Thanks, sir. Thanks.
Haan ji, sir.